same-day ultrasound scan, do our tumour markers, and then the next day they're on the theatre list having their inguinal orchidectomy. Don't forget to pop in the prosthesis, and all's well that ends well. So when Asif asked me to give this talk, he asked me to focus on 4 areas and try and be a little bit controversial. And these are the 4 areas I'm going to touch on over the next 10 to 12 minutes. So the principles of radical orchidectomy, as described in most of the literature and endorsed by the EAU, is doing an inguinal incision, early mobilization of the cord and clamping it at the deep internal ring. And the rationale that is given for doing an inguinal incision is that you're less likely to cut into the tumour and cause tumour spillage. A lot of the bias that was going around not using a scrotal incision came from a paper back in the 1925s by Dean, who reported that by doing a simple orchidectomy, i.e. transscrotal approach, local recurrence rates were in the order of 24%. And it's from here that also the term scrotal violation came about, which includes both doing an orchidectomy, but also a transscrotal open testicular biopsy, and also fine needle aspiration of a testicular tumour transscrotally. But since that paper, its validity has been brought into question, and there's 2 main studies that have really addressed this. The first one was by Capilouto, who systematically reviewed the literature to identify all series where there were cases of scrotal violation. In total, he was able to compare 206 versus a denominator of nearly 980. The endpoints that they were addressing was local recurrence rates, distant recurrence, and overall survival, and they did go about stratifying them into low risk, i.e. stage 1, patients who also had seminoma versus non-seminoma. And in addition, they looked at the additive benefit or not of those patients who went on to have local treatment when there was scrotal violation. In summary, there was no difference in all the endpoints except for a statistically significant increase in the local recurrence rate from 0.4 to 2.9% in those that had scrotal violation. Although significant, the absolute rates were very low. The other paper was by the Indiana group and Leibovich, and they took over about a 30-year period all the retroperitoneal lymph node dissection they'd done for patients with non-seminoma germ cell tumours, just over 1,700. They retrospectively then reviewed all those to see which patients during their primary testicular treatment, i.e. their orchidectomy, had had a procedural deviation, i.e. undergone scrotal violation, and they picked up about 5% at 78 patients. They then reviewed what was additively done to those patients. You'll see there at the bottom of that table, in 56 of that 78, patients had concurrent or shortly after interval hemiscrotectomy. In those patients, only 6 were found to have disease within that hemiscrotum specimen. And just to note that in those 6, all those patients had significant tumour spillage documented at the time of their scrotal violation. Also to note that in 5 patients who subsequently locally recurred, i.e. in the inguinal region, there was no tumour found in the hemiscrotectomy specimen, indicating there may be no added benefit for doing that procedure. There was no change in the overall survival, and in all patients that ended up having chemotherapy because of metastatic disease, there was no local recurrence. One of the other things that's documented huge amounts in the literature is the whole idea that you're doing an inguinal approach, because if there is tumour spillage, the first localization of tumour would be to the retroperitoneal lymph nodes. Of course, this is not true, because the lower abdominal wall also drains to the inguinal nodes, as does the scrotum. So why use an inguinal approach? Well, it's probably not because of the local recurrence rates, but it does allow early clamping of the cord. It also allows you to excise the cord, and of course, there is the risk of T3 disease and therefore leaving a positive margin. And in the small percentage of patients that go on to need a retroperitoneal lymph node dissection as part of their additive treatment, you're restricting that procedure to a laparotomy only and not needing to have an extra incision to excise the remnant cord. By using an inguinal approach, you're less likely to breach the tunica vaginalis than you would be through a transscrotal approach. And of course, there is the issue of the eroding prosthesis if you use a transscrotal incision. So is there any evidence to actually suggest you do need to clamp the cord early on? When I was reviewing the Indiana series, they also very helpfully reviewed all the literature for us. And you see that in most of those studies, there was no change in the overall survival or systemic recurrence rates, except from one particular author, Pizarro. He, in fact, rather uniquely, as was allowed many years ago, did an observational study of 85 patients who had clinical stage 1 non-seminoma germ cell tumours. All those patients had, in a proportion of those patients, 22 of them, they had a scrotal violation approach to their initial procedure. And you can see there is approximately a doubling in the rate in those patients who then went on to develop systemic disease. And quite rightly hypothesized that actually excessive trauma to the testicle before you clamp the cord probably potentiates this risk. Furthermore, the risk of the approach, i.e. the transscrotal approach, is as significant as the two other well-documented poor prognostic factors for non-seminal germ cell tumour, having a greater than 50% proportion of embryonal cancer in the specimen and also having the presence of vascular invasion. Moving on to prosthesis, there is a paucity in literature looking at immediate versus delayed prosthesis, certainly no randomized controlled trial. So where else can we extrapolate from the literature? Well, this is the series from Northwest England, coming out of Salford and the Christie, and through their conglomerate of organisations in the Northwest, they reviewed all men that had undergone orchidectomy. About 50% of them were offered prosthesis, and in those, about 50% accepted, i.e. an overall rate of about 25%. 99% of them had a prosthesis inserted immediately at the time of their orchidectomy, only 1% had a delayed insertion. Overall, the immediate insertion was safe. There was no difference in length of stay, readmission rates, return to theatre, and overall the need for subsequent removal of the prosthesis did not appear to be different between those that had it inserted immediately versus in a delayed manner, except, of course, the numbers here are very small. Particularly, though, they noted that in no patient was there a need to delay any adjuvant chemotherapy because of a complication from immediate insertion of prosthesis. So if it's safe, are patients satisfied with it? Well, in this review of the literature, they demonstrated that the large majority of patients were overall satisfied with their prosthesis and would make the same decision again if they needed to. However, in some patients, there is bother from having the prosthesis inserted. And you note here that when they ask patients about the bother in terms of during exercise or during sexual activity, about 1 in 20 and 1 in 6 and 7 patients, respectively, documented some bother, which is significant. And if patients do have issues with the implant, it generally relates to size, weight, texture, and in particular, the scrotal position. This is what's led to some of the debate in the literature around do you secure it with a suture versus not, but asking the patients to daily draw down the prosthesis and then waiting for a pseudocapsule to develop. But what happens to those patients who don't have a prosthesis? So this is a snapshot of a piece of data from the Sonoelastography series, the series from Sweden and Norway. And they again had an uptake rate of about 25% of patients accepting prosthesis at the time of orchidectomy. What they then did was follow up the patients via postal survey many years later. This is a mean follow-up of about 11 years. And they asked them about their feelings of having lost the testicle, but also issues around body shame and also body uneasiness. In summary, there appeared to be no difference between patients that either had a prosthesis or did not have a prosthesis. The important factor which seemed to increase patients' poor feeling around loss or uneasiness was whether the patient was or was not asked whether they actually wanted one at the beginning. If the patient is asked but declines, in the long run, they're generally satisfied with that decision. On to the last thing, can you delay the orchidectomy for sperm banking? A lot of the anxiety around getting on to do the orchidectomy quickly is based on the half-life that is taught to us, i.e. for beta-HCG, about a day to a day and a half, and for AFP, about 4 to 5 days. But of course, this is a pharmacokinetic phenomenon, how the tumour markers are removed from the body and doesn't necessarily relate to the biology of the disease. Of course, only about 1 in 2 germ cell tumours have a raise in their tumour markers. I couldn't find much literature documenting the actual doubling time of germ cell tumours, apart from a comment by Ritchie in 1993 that the doubling time is probably in the order of 10 to 30 days, meaning that you may have a bit of a bigger window in order to sperm bank. Something that's often quoted is, of course, well, if you're taking off one testis, you've got the other one. Surely that's all that you need. In this series back from 1991, they demonstrated that in patients that had an orchidectomy for testis cancer, only about a third of those actually had a normal semen parameters after the orchidectomy. So about 2/3 to 3/4 of patients have suboptimal fertility potential. And it is well known that 3/4 have a decreased baseline spermatogenesis at the time of diagnosis for a number of reasons: pre-existing defects in spermatogenesis, history of cryptorchism, hormone production by the tumour, potentially anti-sperm antibodies, of course issues with the contralateral testicle, and generalised stress associated with the illness. And if you miss the opportunity to sperm bank, of course, patients could continue down the path of treatment, may go on to have additive chemotherapy. And in those patients that do, although there is documented recovery of their semen parameters after chemotherapy, you will note that there is a significant increase in those patients that end up azoospermic as opposed to those that have oligospermia. Of course, the oncologist would quote that actually they're not only treating the cancer, they're also treating the fertility. As you can see from baseline, there's improvements in overall fertility, but that's just a bias of the follow-up due to loss of follow-up. In addition, you may have patients that go on to have retroperitoneal lymph node dissection, and there is, of course, the issue then of ejaculatory dysfunction. So is there any evidence to support a delay or not in overall, is there any evidence to tell us whether there's a change in the survival if you delay the orchidectomy or not? This is a series from British Journal of Cancer from 2 years ago, where they reviewed not just testicular cancer, but all cancers, looking at every single piece of literature. The jury is out, in essence. There is no evidence to support either way, where there is an improvement in survival if you operate more quickly. The reason you can't come to a definitive answer is that the literature is just so heterogeneous. And this is the main problem. All the series out there, mainly because they're very, very old, don't adequately split up the different sections of the patient pathway. All they tend to record is time of symptom onset and time that treatment happened. And of course, in secondary care, we can control this area here from when they're referred into the hospital, but we can't control the patient delays and, of course, any delays from primary care. So in conclusion, I would say that I think inguinal orchidectomy is very much supported, but maybe not for the local recurrence rate that's historically been taught. Clamping the cord, well, frankly, why wouldn't you, to be honest? The issue around the prosthesis seems to be more about offering and counselling the patient about it, as opposed to absolutely suggesting they have it or not. And in terms of the delay in the orchidectomy for cryopreservation of sperm, I think we have to consider a lot of the practical issues around this. From the evidence out there, 30 days seems to be an acceptable delay, but of course, what I've said earlier, we can't really control any patient delays that have come into that, so we'd very much have to take it on a patient-by-patient basis. Thank you.
Thank you. Thank you, Eric. I just wonder if you'd like to join us up here in preparation for the discussion at the end. As Trevor was mentioning, there is an opportunity for people to pose questions that we can ask later. So if there are points that Eric has raised that you'd like to either question or challenge, then could you please put them down and we'll include that in the panel discussion. So moving on from, I guess, general adult urology and the issue of the testicular mass and how to manage it, we'll now move to the paediatric situation and perhaps a step back with the undescended testis. And Paul Jones will enlighten us both with respect to the paediatric situation and also the adult who has a delayed recognition of an undescended or cryptorchid testis.
Great, thank you. Thanks, Mr. Chairman. Thanks, ladies and gentlemen. So I'm going to chat to you about the management of the undescended testis from cradle to grave. Now, in honesty, about 95% of people are treated before the second birthday, and there's a dearth of literature on the post-pubertal management of the undescended testis, but I'm going to mention that later on and go through the evidence that there is. So firstly, basic definitions are, well, cryptorchidism exists when one or both testicles are not present within the dependent part of the scrotal sac. After circumcision, which is undertaken for non-medical reasons, orchidopexy is one of the commonest operations performed in a healthy male child. And it's common. About a quarter of prem baby boys are born with this, but that decreases to 5% of newborns, and then there's an increase in testosterone in the first 3 months of life, such that it only affects 1% of one-year-old males. 10% of them are bilateral, and when it's unilateral, the right side is more commonly affected than the left, and the incidence appears stable. I'm not going to go to town on the embryology. Suffice to say that there are 2 stages. There's the transabdominal phase, which is insulin-like 3 factor dependent, and there's the transinguinal phase, which is in the 3rd trimester, which is calcitonin gene-related peptide and testosterone dependent. So the pathophysiology involves several proposed mechanisms. There's the endocrine, where there's too little testosterone or too little insulin-like 3 hormone or too much estrogen. There's maternal factors such as alcohol, smoking, diabetes. There are mechanical factors if there's a large patent processus vaginalis and or if they have a hypoplastic abdominal wall musculature, such as prune belly syndrome. And neuromuscular factors such as the genitofemoral nerve, if that's in any way abnormal, then it fails to secrete the calcitonin gene-related peptide. Undescended testis can be acquired through iatrogenic purposes, principally through inguinal surgery and inguinal herniatomy being a typical example, where the resulting scar tissue can sometimes form an anchor, and as the abdominal wall elongates during growth, that causes proximal migration of the testicles through the canal. And they can be congenitally absent or anorchic. So the commonest places you'd find a true undescended testis would be suprascrotal and inguinal, but they can be abdominal. If they deviate from the normal anatomical pathway, then they're classified as ectopic, and the commonest ectopic location is in the perineum. 80% of undescended testicles should be palpable in clinic, though. So the treatment trends are quite unusual. Over the last 30 years, there's an apparent decline in the UK orchidopexy rate using HES data to the order of about 40%. Now, I've already told you that the incidence appears quite stable for undescended testis. I don't think there's any failure in the diagnosis or the screening on the day 1 check and the subsequent healthcare visitor checks. And I'm not convinced that we're managing this wrong, because the current rate of orchidopexies is 1.8%, and I've already told you that it affects 1% of one-year-olds, so we're doing too many orchidopexies as is. And the reason for that is retractile testes, a failure to appreciate that these don't need an operation. This is a physiological condition where the testicles can be milked quite easily from the groin into the scrotum, and they remain there without tension. The natural physiology of this is that as the child gets older, usually about 8 or 9 years of age, the testicular volume increases, and that prevents its proximal migration back through the inguinal canal. Now, follow-up is out to the jury. If it's a very easy examination, I think it's pretty reasonable to discharge the child there and then. But there's a theory that if they're difficult, if they're quite hard to get down into the scrotum, but they remain nonetheless, then it's worth following them up on an annual basis. And the reason for that is a recently described phenomenon called ascending testicles. And this is where a testicle has been previously documented intrascrotally on the day 1 postnatal check or subsequent health visitors, and is then found to be absent. And the theory behind this is that instead of the PPV disappearing, it remains as a fibrous remnant, and that pulls the testicle up through the canal as the child grows. The peak presentation seems to be about early puberty. So when you referred a child with an undescended testicle, the pertinent things in the history are to elucidate either from the birth records or from mum and dad, has the testicle been there before or not? If there's a positive family history with dad or brothers affected, then that poses an increased risk. If they're premature, then you need to do the gestational age-matched equivalent, and you need to know if they've had any surgery, specifically any groin surgery. When you're examining them, you need to find out, is the scrotum on that side underdeveloped or hypoplastic, because that implies that the testicle has never been there. Similarly, on the opposite side, if the testicle is demonstrating hypertrophy, then it's usually compensating for an absent or dysfunctional testicle on the other side. The soap test is very easy to do, either using liquid soap or gel, whatever's available in clinic. You just milk from the deep inguinal canal to the superficial ring to see if the testicle can be produced into the scrotum. If it's not in the anatomic location, you need to look in the ectopic locations. And if there's associated hyperspadias or micropenis, you need to get the involvement of the pediatricians and possibly the geneticists to consider disorders of sexual differentiation. And if there's a large patent processus, that can sometimes, again, hide a testicle. So diagnostically, essentially, surgery remains the procedure of choice. Ultrasound is very rarely helpful. It's very low sensitivity and specificity. CT is a huge amount of radiation and, again, poorly sensitive. MRI is very expensive. You've got to give the child a general anaesthetic to undertake it. It's got a high false positive rate, and it's not widely available. Endocrine evaluation is limited. We don't undertake much in the way of HCG stimulation here, but in Europe it's more widely used. But if you're considering if a child has bilateral absent testicles, then you can confirm chemical anorchia with very low MIS and inhibin levels and very high FSH levels. And some people would say that means they don't need a diagnostic laparoscopy to confirm if the hormone profile suits it. So the first thing that mum and dad will do when they come in is often have Googled the condition and be absolutely convinced that their child has got an unexploded time bomb of cancer that's just waiting to happen. So I think there's a lot of reassurance in the facts, in the stats. If you tell them that there's a 1% overall risk of that testicle turning malignant. If you do the orchidopexy before puberty, it appears to be lower, about 2 to 3 times. If you do it after puberty, it's slightly higher, 4 to 5 times. So unilaterally, one undescended testicle, the risk of it turning into a tumour is 1 in 120. And bilaterally, that increases to 1 in 44. The subfertility is not that bad. The semen analysis is worse than the paternity. If a unilateral undescended testicle is successfully orchidopexied into the scrotum, that person will have an 80 to 90% successful paternity rate, which compares favourably with a male with 2 healthy intrascrotal testicles that's never had any surgery, whose paternity rate would be 90 to 95%. Understandably, that decreases when both testicles are operated on and drops from 45 to 65% success only. They're more prone to tort in the groin if they're not treated, and cosmetic considerations are important to ensure that the scrotum looks as symmetrical and as well developed as possible. So the treatment, well, we know ideally the earlier you can treat it, the more chance you have of preserving every bit of function that testicle has. From the age of 6 months, you see dark Sertoli cells appearing, and there are some advocates to say that you would need to do the surgery ideally between 3 to 6 months of age. But there is no proof at all that dark Sertoli cells at 6 months causes an irreversible decline thereon in, and the function of the testicle drops off a cliff thereafter. Nothing at all. So we know that early surgery can reduce the potential for malignancy, and the jury remains out. I think everybody would agree in the UK that this surgery must be undertaken before the 2nd birthday, and ideally around the 1st birthday. But you have to consider local factors, such as your anaesthetist and what they're capable of and happy to undertake as well. So the success rate of orchidopexies depends on where the testicle is. Unsurprisingly, the higher up it is, if it's intra-abdominal, there's more tension on the blood vessels, more tension on the vas, and it's got a higher attrition rate. So about a quarter of the testicles that you fix from the abdomen will shrink. That decreases the lower down you go to the groin, so you end up with approximately a 5% atrophy rate if the testicle is in the distal inguinal canal. The consent, well, if you can't feel a testicle, you need to consent mum and dad for an examination under anaesthetic and possibly a laparoscopy. If you can feel a testicle or the laparoscopy shows that the vas and the vessels are converging at the deep inguinal ring, you should do an inguinal exploration with the intention of fixing the testicle via an orchidopexy. If there's only a nubbins, then an orchidectomy is best undertaken. There's a 2 to 3% chance you'll need to do a Fowler-Stevens, which I'll mention shortly. And the benefits speak for themselves, which are to place the testicle in the scrotum to facilitate optimal development. The risks are infection, bleeding, the testicular shrinkage, as I've said, depending on where the location of the testicle is, and a 1 to 2% chance of the testicle reascending. If you can't feel a testicle in clinic, the first thing mum and dad will say, well, what are the chances are you going to find a testicle? And it's pretty much 50-50. 40% of the time you'll feel an intra-abdominal testicle. 10% of the time you may feel a testicle, especially in a larger chubby child with a prominent suprapubic fat pad, to the order of 10%. So about half the time you're likely to find a successful testicle. The procedure is quite straightforward. You just undertake a transverse skin crease incision. You divide the gubernaculum. You skeletonize the cord by removing the patent processus vaginalis and cremasterix, and then you reimplant it via a Dartos sheath. And the before and after, that usually takes about 20 minutes. You can see the testicle was here, and that's now been transposed into the scrotum with absorbable sutures, and usually the post-op recovery is uneventful, and they all go home about 4 to 5 hours after the case. Fowler-Stevens, as I mentioned earlier, is something that you would reserve for high intra-abdominal testicles, and it sounds counterintuitive, but you deliberately divide the testicular vessels, and you're encouraging a collateral supply to develop from the vas, which has got a much longer pedicle. Then 3 to 6 months later, you transpose the testicle down into the scrotum. You can also mobilize the vessels intra-abdominally on the peritoneal membrane and potentially move them medial to the epigastric vessels, and that can give you about 1 centimetre of extra movement. Follow-up is straightforward, 3 to 6 months after the case, and you're just comparing the contralateral side, the healthy side, to the one that you've taken down in terms of shape, size, symmetry, and lie. If you've had to remove the testicle or not found a testicle, usually mention to mum and dad at the age of 16. If they'd like to have a discussion about a prosthesis, then you'd be happy to undertake that. Post-pubertal, as I said, there's very little evidence for. The malignant risk is there, but it's not as big as previously described. Yes, it's up to 5 times increased, but it's still only 1%. When you think a female has a risk of breast cancer to the order of 1 in 14 or 7%, it puts it in a bit more perspective. But you need to have the discussion. And in a similar way that we counsel people with PSA and active surveillance, to some people 1% is too much, to some it's not at all, and they would consider conservative management. Subfertility, there's very little out in the literature about that, but unsurprisingly, the older you get, the less chance you have of having good viable spermatozoa. The largest series that I could find was from Korea. The median age was 32, and they undertook 25 orchidopexes and showed that there was a viable spermatozoa in only 1 of those. And there are risks of torsion and also cosmetic, which is very important post-pubertal to most guys. So the treatment options, well, unilaterally, it depends on the appearance. If you've got what appears and feels like a largest testicle and it's in the distal inguinal canal, then it's perfectly realistic to try and get that down into the scrotum. If there's any abnormality or you suspect one, then you consider a biopsy as well. But you should always consent them for an orchidectomy. There's a higher risk of malignancy, so you obviously have to counsel the patient preoperatively what they want. If 1% is too much for them, then there's very little point in you endeavouring to try and transpose the testicle down if they just want that risk removed and a prosthesis instead. If there's a mass, then you need to treat it as a testicular tumour as you would with anybody else. With bilateral undescended testis, as I've said, with the endocrine, very low MIS and a very high FSH suggests anorchia. You could undertake semen-analysis if there is anything potentially there of any value or any function, then it's certainly worth preserving that before you irreversibly damage it further still by undertaking surgery. They also need to be consented for orchidopexy, especially if you can feel gonads which are in the distal inguinal canal, but you have to be realistic and say that orchidectomy is a significant possibility. Several papers in the last 10 years have commented that 50 years is a reasonable cutoff, that the risks of the general anaesthetic outweigh the risks of the surgery, and both of those are very small, or if the patients have got significant comorbidities. So really, a lot of this should come down to patient preference, what they want. It's the psychology of removing that 1% risk or surveillance. Cosmetic importance is often underplayed. Having a prosthesis is what a lot of guys will want. They want the risk of the tumour potentially removed sometimes, but equally as important is to restore a symmetrical appearance. And you have to be realistic, because unlike a 6 to 12-month-old groin, which has got stretchy, plastic, elastic sort of tissues that are quite easy to move, in a guy in his 20s plus, the tissues are anything but that. They can often be very non-compliant, very difficult. Even skeletonizing the whole thing back to the vas and vessels doesn't provide anything like as much flexibility. So the majority, but not all, supports orchidectomy post-puberty, but you have to review every case on its own individual merits. So to finish, referral to a specialist should be made by 6 months of corrected gestational age and endeavour to correct the undescended testicle around about the first birthday. The diagnosis is one that's made on physical examination. Most testicles are palpable to the order of about 3/4 to 80% of them, and they're usually in the very uppermost part of the scrotum or the distal inguinal canal, but 20% are not palpable. Boys with newly acquired or ascending testicles should be treated in the same way as primary undescended testicles. And we know that a lack of treatment, especially pre and post puberty, has got a significant difference in terms of the heightened risks of cancer and subfertility. And when you're counselling anybody about a post-pubertal orchidopexy, it just needs to be careful and realistic. Thank you.
Thanks very much, Paul. Just out of interest, can you put your hands up here if you do orchidopexies in children? Hands up in the room. Okay, that's quite a few. Great, thanks very much. Paul, you can join us here if you'd like. Our next speaker is Claire Allen, who's a consultant uroradiologist in London, so we're very thankful to her for coming along today. She's going to tell us all we need to know about ultrasounds of testicular lesions.
Thank you. Thank you very much for asking me to come to Glasgow. I came on one of those Pendolino trains and I've had about an hour to get... Wow, they make you sick. Thank you very much. I'm going to talk to you a little bit about ultrasound of the testis. We do about 3,500 to 4,000 ultrasounds a year at UCH, and we have a large number of patients sent to identify the cause of their scrotal masses, but we also have patients coming to us as part of their fertility investigations. And in a substantial percentage of patients, we will actually find something that hasn't been palpable or known about. And about, in the literature, 1% to 7% of patients sent for just an ultrasound for other reasons, we may find a small lesion in a testis that we need to try and determine which of these three groups it is part of. So our job as radiologists is to try and tell you whether we think we're looking at a malignant tumor, such as a germ cell tumor, metastasis, or lymphoma, a non-malignant tumor, and it would be interesting, I think, for me radiologically to hear what the urologists think now about the malignant potential of Leydig cell and Sertoli cell tumors and other Sertoli and other stromal cell tumors. And of course, all of the non-neoplastic mimics, which become a major problem for us. And these are they, and it's important to know about them because many of them have very classic grayscale ultrasound appearances, which you just need to know about and be careful when you do the scans. And quite a lot of these you can determine that they're present and you don't make the mistake, particularly with things like epidermoid cysts, that you call them tumors. So when we can't put a lesion into one of these three categories, we call it indeterminate. So our bread and butter for looking at the testis is high-frequency ultrasound, and one of the things over the last, I'm afraid, long time for me, 20 years plus, doing ultrasound, the quality of the ultrasound images is so good now that we are seeing lesions that we would never have seen 10 or 15 years ago. So 2 to 3 millimeter lesions in the testicular parenchyma, and that's where quite a lot of our bother and our problems arise. One of the major things that we need to do is determine intratesticular from extratesticular. Obviously, extratesticular has a much lower malignancy rate. And I read in the literature all the time that MRI is best for this, and I really think ultrasound is the best for this. You have the testis or the scrotum in your hand, you have a probe where you can look at the lesion from any single angle you want, and you should be able to tell whether you're looking at an epididymal lesion, which is indenting the tunica, or whether indeed you're looking at a tunical lesion. And I think taking a sledgehammer to crack a nut which I will talk about later, is probably not appropriate. Simple cysts we can ignore. It's very important for us to be able to determine those versus slightly more complex lesions. And all of these other things is what we look for on our grayscale imaging, particularly the margin, the echotexture, and the presence of calcification is very important, as the majority of tumors will contain some calcification. I'll also talk a little bit about vascularity. So in 2015, the European Society of Uroradiology got together a subcommittee. I wasn't on it, but a couple of my colleagues were on it, and they put together from the literature the appearance of lesions that would put them into a benign or a malignant category, and you can see that there's quite a lot of a grey area in between, and that's a major problem. So small lesions are generally benign, larger lesions are more likely to be malignant, but there is a large crossover. There's really very little new literature on this. I was quite surprised when I was preparing for this talk how little there is. This is a prospective review from Rome from a couple of years ago now, basically showing what was important in determining benign from malignant. And again, you've got an irregular margin and the presence of calcification as your two major ultrasound factors determining whether you're looking at a malignant lesion. So let's look at some ultrasound. So these are quite categorically malignant. You've got large lesions, heterogeneous, irregular outlines, large lesions, well over 2 centimeters in diameter, some cystic areas, some microcalcification, and here in a very abnormal testis, lots of microlithasis, about which we might speak later, a large hypoechoic lesion with calcification. And I think everybody would be very happy to call all of those categorically malignant. And then we've got some benign lesions, which again we need to be able to confidently categorize as benign. So you have simple cysts with absolutely no wall, hypoechoic, posterior acoustic enhancement, no abnormality in the surrounding parenchyma, and no abnormality on color Doppler. You have epidermoid cyst, and we have quite a lot of orchidectomies in the past have been done to remove these as they were diagnosed as tumor on ultrasound, but I think we have got a lot better at determining these benign lesions. They're very well defined, they've got a lamellar appearance, an onion skin type appearance, and again are non-vascular epidermoids. Sometimes you can get cystic lesions within the testis that look quite nasty, but if you look at where they are, they're sitting around the mediastinum of the testis, and these are lots of Reti's cysts all sitting together, giving the appearance of perhaps a malignant cystic mass. So in ultrasound, you just have to be very careful. One of the mainstays of ultrasound is putting color Doppler on, and that can be very, very good at separating the mimics from the malignant and the less malignant tumors. So here you have a malignant tumor, a seminoma with abnormal color flow sitting around it. Here's a lesion that looks very similar. This was a patient who had had trauma to the scrotum, and this was an intratesticular hematoma with absolutely no color signal at all. So what we can do is suggest that that's the likely diagnosis. But as you all know, we always review these scans and bring these patients back just in case they have a small underlying lesion which has caused this large hemorrhage. Infarcted testicles can look very similar to tumors, but again, there's no color flow within them. And one of the things that we're getting much better at being able to determine is testes that have some segmental atrophy within them, where you get geographic areas of reduced echogenicity, almost mass-like, but again, absolutely no color Doppler signal around them. So color Doppler can help distinguish between some of the mimics versus the tumors. One of the difficulties we have is the differentiating between the germ cell tumors and the less malignant potential tumors, the Sertoli and Leydig cell and other stromal tumors. So this is a Leydig cell tumor, and they do show abnormality on color Doppler imaging, very similar, these are all Leydig cell tumors, very similar to a germ cell tumor like a seminoma. And this is one of the problems that makes it very difficult for us sometimes to distinguish, particularly when they're larger, whether these could represent a germ cell tumor or whether they're the less problematic stromal cell tumors. So often we're still unsure, so what do we do? Sux is going to talk a little bit about removal and biopsy after me, so I'm not going to talk to you about that. Interval ultrasound is one approach because anything that is active should enlarge in time. We have absolutely no data on what enlargement is significant, how much, in what period of time. We have absolutely no data on change in color flow or any other parameters like that. And most of the time, these sort of decisions are taken in an MDT. And of course, there's do another test. In terms of interval ultrasound, there is no approved recommendation. ESUR in 2015 took a look, and they suggested for serial ultrasound monitoring that it's 3 monthly for a year and then yearly after that, and surgery if the lesion increases in size. But again, one of the things we might discuss is interval scanning and what approach we take and how often we think it should be done, and perhaps by whom. So, do another test. What do we have out there that we can do to try and help us with our indeterminate lesions? Well, these are the 3 suspects: contrast-enhanced ultrasound, elastography, and MRI. And in our institution, we do none of these. And I think that these have been around with us now for the best part of 15 years. And I think that if they had shown any great merit in the identification or help with indeterminate lesions, we would all be using them. And as you know, I'm a great MR advocate. And if I could, I would use it. But let's have a little look at what the data shows with those. So contrast-enhanced ultrasound, one of the problems with this is not only is there very little data, but you actually need to have programs within your ultrasound machines to allow you to do them. And most of your normal standard hospital ultrasound machines will not allow you to do contrast-enhanced scanning. The literature also suggests that in order to make a determination between a malignant lesion, such as a germ cell tumor, and a slightly less malignant lesion, like a Sertoli cell or Leydig cell tumor, that you need to actually do a curve analysis. Well, unless you're in an academic center, this sort of ultrasound is really beyond just general scanning. They showed some benefit with contrast, but again, there was quite a significant overlap between these two tumor types. Elastography we use now particularly for livers, looking at stiffness and looking at fibrosis in livers, but you can use it for any tumor types, and it's also been used in the prostate to try and identify areas of prostate cancer. And rather like in the prostate, it's been used in the testis, and we can easily see areas of abnormality within the testis, but again, there's too much overlap to be able to tell whether these lesions are germ cell tumors or whether they are Sertoli or Leydig cell tumors. There is some benefit in determining the tumor mimics, but we have lots of other ways of being able to tell it's a tumor mimic, and we don't need to use this. And again, one of the problems with this is that you require an ultrasound that is set up to do this. The machine has to have a certain protocol set into it, software, and most ultrasound machines don't have it. So MRI, my favorite test. We do not really use it very much for scrotums at all in my institution. Most of the papers that have been written in the literature on MRI have been written by people without access to ultrasound. And I think many of the things that have been advocated that MRI can do, ultrasound can do better, cheaper, and quicker. One of the other problems with the papers that have been written is that most of the work on looking at these tumors within the testes have used contrast enhancement and curve analysis, so that a malignant curve would be this one, a benign curve this one, and then an indeterminate curve, the one in the middle. And the problem with doing that is that actually is complex on MRI and requires quite a lot of workstation analysis, which we don't even do for the prostate. So it seems a little odd to be doing it for the testicle. So again, I think MRI at the moment isn't particularly useful. So where are we at with testicular lesions and imaging? The most important thing is to characterize your lesion with a really good quality ultrasound, and that's not only the machine, but it's actually the operator as well. Most small non-palpable lesions are benign. Leydig cell tumors are the most frequent benign lesion, and perhaps we can talk about how benign they are. Interval ultrasound for indeterminate lesions, 3 monthly suggested, but again, something that we can have a debate about. And at the moment, we don't think that there's much role for MRI or any of the other techniques to look at the testis in terms of making this differentiation. And this is from ESUR 2015. Thank you.
Very enlightening. If you'd better come and join us. Just as a quick question while our next speaker steps up, can I... Obviously, ultrasound's useful for indeterminate lesions, but could I just ask by a show of hands, would people in the context of a clinical diagnosis, i.e. a palpable testicular tumour, who would always undertake an ultrasound before proceeding to orchidectomy? If you just give me a show of hands. Anyone that would proceed to orchidectomy without an ultrasound? Okay. All right. Well, we'll now move on to the final speaker before our discussion, and Saksminas, andrologist from UCL, will give the urological surgeon's perspective on the indeterminate testicular mass.
Okay. Thank you, David. So I thought this was quite a difficult title, Asif. So it took me quite a long time to try and work out what to talk about. And as Claire's already outlined, the evidence base is very limited. And what I'm going to share with you is some data that I have in terms of follow-up on my patients, but you have to place this into context of the fact that I'm seeing a lot of infertility patients who I'm routinely scanning. So these are the various clinical scenarios that you may be faced with. Patients presented with a palpable indeterminate lesion of the testis, which we're not going to really talk about because what we want to talk about is that impalpable indeterminate lesion. Patients presented with incidental indeterminate lesions of the testis detected at the time of ultrasound scan evaluation, whether that's for subfertility, whether that's for pain, and various other causes, or patients being evaluated for a varicocele. And also those patients with indeterminate lesions and azoospermia. So you've got to remember that most of the patients that I see, so every patient that I see in clinic with subfertility, I do an ultrasound scan of, and I'm going to justify that later on perhaps, but I haven't got time in this talk to talk about that. So this is a paper, the review article, which is very good actually, which Claire wrote and looked at indeterminate lesions. In fact, this is a Leydig cell tumour on this scan, and you can see the peripheral vascularity here. And I think we're rather spoilt at UCLH that we have extremely good radiologists who are very capable. So what kind of lesions, what's the sort of ultrasound findings? Now, Claire put up the sort of guidance from the radiologist, and I have to say that probably confused me even more just before my talk to stand up and talk about what I think should be biopsied and what patients we should be following up. But overall, if you look at data, most patients would say that if you have an ultrasound scan finding of a single small 1 centimeter testicular mass, you might want to consider hematoma, infarction, sarcoid, and as a differential. And this is where the ultrasound-guided biopsies, which I'm going to talk about, play or come into play. Some patients may already have a tumour removed. You're worried they might have a small lesion which shows maybe some peripheral vascularity or no vascularity, and you don't want to follow up that patient because they've already had a tumour, either in an undescended testis or on a background of TML, and you begin to think to yourself, well, actually, should I be biopsying this? The problem, of course, is that we may be over-treating, and certainly I'm aware of a medical legal case of a patient who had a 3 millimeter lesion removed and underwent radical orchidectomy. There was a vascularized lesion. You may argue, well, is that wrong? And certainly he's got another testicle which is functioning. So we need to try and get some form of guidance in this very difficult area. So I think that there are clearly other scenarios, orchitis, trauma, vasculitis, all of which can, in a sense, mimic malignancy. So we have to be very careful, and often the default is, of course, radical orchidectomy because you're going to be saving the patient's life potentially or not missing a tumour, and for medical legal reasons, you may not wish to undertake radical orchidectomy. So here's a sort of typical patient that I may see, 36-year-old. He's had a testicular ultrasound scan. He's got a history of orchidopexy as a child. He's had an orchidectomy. His FSH may be 35, testosterone 20, single testis, and azoospermic. And I'm going to come back to this patient shortly. But these are the kind of patients you might see. And if you look at this scan, you'll see he's got quite florid TML. He's got a vascularized lesion here. And you're worried. And you're worried it's in a single solitary testis. So what can you do? So the options you might consider in this particular scenario are either radical orchidectomy and say, look, if you've completed your family, you might wish to consider radical orchidectomy if fertility or HRT isn't an issue. The problem, of course, is you may be over-treating that group of patients, and therefore you may, in fact, miss the boat in terms of testicular preservation. You could, of course, survey that patient, and of course you've already heard Paul talk about, well, how long is a piece of string? How long is the doubling time of a tumour? How often do you scan these patients? So all of which raises complexities in terms of management. The problem, of course, is no existing guidance, okay, or no existing protocols in terms of management. And, of course, the final thing we can talk about is ultrasound-targeted biopsy, which is what I'm going to talk about in a second. So just to highlight very quickly about contemporary role of testis-sparing surgery, historically, those patients who have bilateral or synchronous tumour or solitary testis with malignant lesions, you can, of course, preserve the testis. But the assumption, of course, primarily is this is a malignant lesion and you can perform frozen section analysis at the same time. The problem I have, of course, with this type of surgery is fundamentally, if you look at historically studies, most of these patients or tumours will occur in a background of intratesticular germ cell neoplasia. So again, giving these patients adjuvant treatments will impair further their hormone function and spermatogenic function as well. So it seems to be counterintuitive in that context. But there are many studies, and I've outlined them here in terms of studies reporting on outcomes. And again, if you look at the EAU guidelines, you look at the German group, you can see here that the main issue about follow-up and outcome in terms of testis-sparing surgery in this context in patients who have malignancy is the fact that follow-up times are very short, hormone follow-up is very limited, and in fact, many of the patients, a significant number, have recurrences, and furthermore, many of them require adjuvant therapies, and in terms of adjuvant therapies, you then may impair hormonal function. So again, it's a difficult group. And again, you might end up forming a radical orchidectomy in that patient who manage to preserve his testis. These are some of the appearances. It's an MRI scan post-treatment. You can see here that testicular preservation can occur. Again, if you look at studies, and just to highlight, again, this is the French series looking at testis-sparing surgery in these kind of situations. But again, one thing to note, many of these patients require adjuvant treatment. There is no adequate follow-up data in terms of outcomes, in terms of fertility, nor hormonal function, which is clearly important in this set of patients, and hence I'm moving now to this group of ultrasound-targeted patients. So what is the technique? You've clearly got that indeterminate lesion. You don't know what this lesion is. You've got to weigh that patient up. So first of all, you've got to do their tumor markers. You might want to do a full blood count to exclude myeloproliferative disorders. But again, it's a difficult scenario. Let's assume those tumor markers are normal. Let's assume it's an impalpable lesion, and you're left in that scenario with a lesion. So how do you manage that? What are the features that might just push you into either biopsy or non-biopsy? Of course, you've got to discuss that with the patient. But I'll just tell you about the technique first of all, and to place this into context in a second with some results. So ipsilateral inguinal incision, you already talked about non-traumatic clamping or clamping. Does it make a difference? But of course, that's up to you. And again, as Eric already alluded to, then it's not going to do any harm. Delivery of testis into the field. An intraoperative ultrasound scan is undertaken, and we're lucky we've got Claire who's done many of these with us here at UCLH. And ultrasound localization occurs by needle localization, where a needle is placed directly into the tumor. Now, I'm going to show you some data. It's quite interesting that you can actually even target lesions less than 3 millimeters, and it does work very well. I tend to use a transverse or longitudinal equatorial incision, essentially allowing me to actually move, because often you can miss the tumor, and often the needle can either go straight through and you're cutting in the wrong direction. I'll show you some pictures in a second. But at the same time, you do a microdissection, in other words, under a microscope to enucleate the lesion. You send it for frozen section. You may biopsy the edges as well to exclude intratesticular germ cell neoplasia if you're particularly worried. But frozen section analysis is undertaken, and then you get the result back. Now, we tend to scan the lesion as well immediately afterwards, and also test this afterwards to ensure that you've actually got the lesion as well. So it does work pretty well. The procedure may take about 2.5 hours to perform, and clearly if the frozen section comes back positive for malignancy, then you can perform a radical orchidectomy on the same sitting. The other issue, of course, is many of these patients may be azoospermic or have severe oligocenotracheozoospermia in the context of fertility, and that's why I'm scanning them, because all my patients have scans, in which case you might want to perform an Onco-TESE or microdissection sperm retrieval at the same time. So this is that lesion there. This is Claire, actually. This is your hands performing an ultrasound scan. The needle is then placed. I haven't got a needle picture, but I'm going to show you an ultrasound picture in a second. A longitudinal transverse incision. What's quite interesting, sometimes you can feel these lesions as soon as you actually deliver the testis. And here I've done a transinguinal incision on this patient. This is actually a needle going in directly into the lesion, and you then cut down on the tunica onto that lesion, enucleate it microscopically, and you send it for a frozen section analysis. So I just want to place this into context in terms of where I'm going to lead up to in terms of treatment of these patients and follow-up of these patients. And in fact, in about 800 ultrasound scans that we routinely performed for men with subfertility, not surprisingly, you detect a disproportionate number of indeterminate lesions. And this just highlights the lesions we saw. In fact, there were in fact 99 testicular units in this set of patients who had abnormalities that were determined as indeterminate lesions. But none of this seemed to be related to previous orchidopexy, the degree of TML. None of these lesions appear to be related to their semen parameters either. And they were defined either as hyperechoic and vascular, hyperechoic with no Doppler flow, or hyperechoic. And that's the importance, which I'm going to show you in some of this data, which we haven't published as yet. Now, if you look at the lesion types, it's interesting. Those that were hypoechoic and vascular, in fact, had a higher proportion of malignant tumours. So in other words, they're more likely to be malignant. In fact, in this series, all 3 cases were seminoma. But also there was an increase in number of Leydig cell tumours as well. Now, whether you classify those as malignant or non-malignant, of course, we can discuss. And then the other group, of course, included Leydig cell hyperplasia and Sertoli cell adenomas as well. The key here was vascularity, or lack of vascularity. We didn't find any germ cell tumours that were non-vascular. Not surprising, you may think, but certainly in some of the hypoechoic with no Doppler flow, we found that, in fact, there were some that had Leydig cell hyperplasia and Leydig cell tumours. And in fact, the hyperechoic lesions here, many of them are either fibrosis or reported as normal, or alternatively had Leydig cell hyperplasia for these discrete lesions. There was no association with any risk factors. And interestingly, Claire highlighted that 1 centimetre cutoff or 10 millimetre cutoff. And in fact, in this series of patients, there was no correlation with malignancy the potential for malignancy and size. So in other words, size wasn't a predictive factor either, nor the presence of TML, nor the sperm concentration, hormone parameters. But what was if you had a hypoechoic vascular lesion, then you were more likely to have a malignant lesion. So overall, in this group of patients that we're screening effectively for malignancy, 1% of all subfertile men were found to have significant testicular tumours, significant meaning Leydig cell tumours, as I've included in that group, and furthermore, those patients with germ cell tumours as well. So what about other studies? If you look at the literature, I'm afraid there's not much out there in terms of the literature, but again, similar results have been reported in many of these studies, and therefore I think you've got to choose those cases very carefully. If you look at in terms of management, and certainly in that patient who has fertility potential as primary concern, then one of the issues, of course, is that you don't really want to biopsy that patient, particularly if they have oligozoospermia, as you could, of course, damage the testicle. Now, in terms of Schlegel's study, and this is a paper from Schlegel published previously, similarly, they showed that both hypoechoic and vascular lesions appear to have a higher malignant potential. And those patients, interestingly, the tumours above 5 millimetres, and that's where that figure, I think, from the radiologist comes from, were more likely to be malignant as well. So size and hypoechoic and vascularity, both important markers in terms of prediction of malignancy. And those may be patients that you might want to intervene on early, as opposed to monitoring those patients who don't have those features, who you can perhaps delay treatment until their fertility has been treated. So this was his algorithm, and you can see there that if you had a greater than 5 millimetres or it increased in size by 5 millimetres, if tumor markers are clearly positive, fairly obvious, if there's hypervascularity of the lesion and it was hypoechoic, then you consider surgical exploration as I've outlined there. But it didn't really go into exactly the type of surgical intervention that they went into. Based upon our own results, the algorithm that we would propose would be, if you have an indeterminate lesion here, you consider if it's hypoechoic, no Doppler flow, or hypoechoic alone. You could consider surveillance, 3, 6, 12 months. You could argue up to 5 years. There is no firm guidance about this. If it's hypoechoic and vascular, then of course, I think testicular exploration with ultrasound-targeted biopsies and frozen section with a view to orchidectomy may be the best option in that patient. You already mentioned this. I'm not going to dwell on this. Other types of modality that may be useful in terms of ultrasonography. Interestingly, this is a paper here that is looking at true cut biopsy. We've already looked at scrotal violation, the effects of scrotal violation on prognosis and in terms of outcome and recurrence rate, but this is looking at true cut biopsy of these lesions. So this may be an alternative, but then of course you may be worried about oncological recurrence. What about these indeterminate lesions? Just to talk to you a little bit about those with azoospermia. So you may find these indeterminate lesions, they may have vascularity, or you may decide to operate on these patients, and therefore you bring into the concept of something called Onco-TESE. We already briefly mentioned this, but again, transinguinal incision. Essentially the testicle is delivered. You can do a longitudinal incision. You can see here, this was in fact a palpable lesion, and in fact in the lower end of that you can see a tumour there in the picture, and that's sent for frozen section. That came back actually as a seminoma. And on that same testis, you can use the principles of micro-TESE or microdissection sperm retrieval and remove dilated and opaque tubules. Most of the studies are retrospective. Most of the patients contain heterogeneity in terms of follow-up and in terms of outcomes as well. But overall, we looked at some of our patients here, and we performed it in this group of patients here, particularly those with either myeloproliferative disorders or germ cell tumours. And what we did find is that we could find sperm overall in about 42% of these patients. So again, something that you may wish to pursue at the same time as you're performing ultrasound-guided biopsy as well. And this is just a review of the literature in that context. Not many patients in that group of patients. What we did find in terms of sperm retrieval in this group of patients, there were no predictive factors that we could find, both in terms of tumour type, in terms of predicting outcome, in terms of surgical sperm retrieval rates. So I would summarize and say that this is a difficult area, but I think ultrasound targeted biopsy for indeterminate lesions is technically feasible with high success rates for testicular preservation. In fact, in a series of patients we looked at, we had no false positive or false negatives in terms of final pathological diagnosis. Even small lesions, less than 5 millimeters, can be targeted. So I would actually argue about the 5 millimeter threshold that we currently use or has been used by the radiologist. Hyperechoic and vascular lesions are more likely to have significant pathology, so I wouldn't hesitate on operating in that group of patients, although clearly a significant number will also come back as Leydig cell tumours, which, as we know, 90% are of benign type, inverted commas. And I think at the same time as you biopsying lesions, you can consider Onco-TESE, which can be formed simultaneously in those with azoospermia. Thank you.
Thank you very much, Sux. If you could just join us now, we'll try to throw it open to more general discussion. I notice no one's posed any questions yet, so just very quickly to get the ball rolling, I'll ask the panel a clinical situation that I guess all of us as general urologists could encounter, and I certainly have had a case where this occurred, and this is a situation where you've explored a testis on the assumption that it was a torsion, it had all the appropriate clinical features, an acute sudden onset of pain, and having done the scrotal incision, delivered the test, you discover in fact it's a tumour. So there's a number of potential options. I'm not sure whether there's any right or wrong, but just to my way of thinking, there's a number of potential approaches, and that would be to close the scrotum and revisit the situation, given the fact it's an unanticipated finding, whether to proceed with a scrotal orchidectomy, an inguinal orchidectomy, or biopsy and then reinsert the testis and wait for pathology before the management. So just running through those four possibilities, I'm just interested in what people would do. So who would just close the scrotum, then revisit the situation after discussion with the patient? We'll just get a show of hands on that. Who would proceed to a scrotal orchidectomy? An inguinal orchidectomy? And what about a biopsy and revisit the situation? Well, it seems as though there's no consensus within the room, which is good. So I'd just like to just ask the panel, I guess starting from you, Sux, working back in this direction, how would you approach this situation? Because I think it's something that all of us could be confronted with and have to deal with on the spur of the moment.
Sure. Yeah, I mean, I think we've all been there in that clinical scenario. I certainly have. I have to say that I've removed the testicle. I mean, I think one of the things you should do is probably do tumor markers before you take it off in terms of monitoring. I'd remove the testicle. I probably would go transinguinal in that patient. The argument, of course, is you're talking about scrotal violation, and in terms of tumor recurrence, which the evidence base, as Eric has already alluded to, is quite weak. And therefore, in this modern day of cisplatin chemotherapy, you could argue that your survival rates are going to be no more deleterious compared to those patients who've had, who've had classical orchidectomy or radical orchidectomy. So I would have adopted the radical orchidectomy route transinguinally.
Paul, do you have any?
Not much to add. No, if you've got frozen section, it would be helpful. I'd go for the transinguinal approach as well.
But you do a frozen section before you proceeded to...
Yeah.
Eric?
I would probably put a couple of tacking sutures back in the tunica vaginalis. Obviously, you would have opened that as part of your scrotal exploration, just to make sure that when you then go on to do an inguinal approach, which is what I would do, you're actually taking out the whole of the tunica vaginalis. I would obviously do a thorough lavage of the scrotum as well, and then do a primary closure, and then watch and wait. Obviously, you've got to wait for further staging. And got to wait for the final histological diagnosis, because it may well be, as Sux already said, this patient may go on to have some adjuvant chemotherapy anyway, and we know from the limited literature in all those patients they didn't develop a local recurrence. There certainly would be no argument really for doing any hemiscrotectomy, which in the historical series was favoured.
I mean, I think I'd agree. I guess the key thing, I think, is actually removal of the cord as a bigger issue than concerns about scrotal violation, and that people do get stump problems, particularly those who've got widespread disease, that quite a number of them end up having to have quite complex inguinal dissections because they have disease that remains in the inguinal canal.
Great. Well, it's good to know the question system is working. And this is a question for Claire, I guess, really. Is there a role for urologists to train in conducting scrotal ultrasound as part of the clinical assessment in clinic?
The bottom line with ultrasound is it should be done by people who are properly trained, who do enough of it, and who know enough about what they're trying to scan in order not to make any mistakes. We've tried to train urologists at UCH, and they're too busy, like we all are. There was probably about 5 or 6 years ago, I had many registrars who used to come and sit, and we used to do lots of ultrasound. And then they got trained, and then they never used it because they either didn't have access to ultrasound machines, or they were just too busy, and they got out of practice with it. So whilst it sounds good, I'm not sure practically it's a goer. You would have to have a relatively high performance ultrasound machine in your clinic if you had one there. I mean, it is the way the gynecologists have gone, so they all now have ultrasound machines in their clinics. I just think at the moment, practically, we don't have the facilities, nor, but it'd be interesting to see from some of the registrars that are here what they think. Partly, one of my views has always been that X-ray departments should be much more responsive to the clinical needs, and that if radiologists aren't responsive to clinical needs, then we'll start losing things like we lost cardiac angio, vascular angio, gynecological ultrasound. You could keep going down, and I think scrotal ultrasound may be another thing that we might lose if we don't get our act into gear. So basically, I think we should still be doing it.
Okay, what about the specialist andrologist who obviously is largely dealing with scrotal conditions? Do you think that would apply to those people that may be doing it in a high volume setting?
I don't know. I don't know. Ask Sachs.
No, I don't think so. I think the key to many of these lesions being followed up in decision making is very much based upon the expertise of a radiologist, and I can't give you that degree of expertise and experience in terms of ultrasound scanning these lesions. And so I would be saying that no, I think it should remain the domain of the radiologist.
Can I just ask a question? We have our X-ray meetings and we'll show ultrasound images, and the radiologist often says that I've only got 2 images.
Yes. Yeah.
Would you trust the images that you're seeing that's been done by a sonographer, or would you say, look, I need to scan this myself?
That's a great question. So what you can do now on all the ultrasound machines, and what we tell all our sonographers to do, is to take video clips. So you're actually not seeing 2 static images, you're actually seeing a clip scanning through the testicle, so you can actually see the lesion in its entirety in real time. And I think the key for getting good testicular ultrasound is to have multiple video clips saved. And that's what our sonographers do. They know that if they see something that they're not quite sure, they take multiple clips, they put the color Doppler on, they take clips of that. And usually, if you've got that, then you can make a diagnosis from the images. But I absolutely agree with you. If you've only got 2 static images, it's almost impossible to make a diagnosis from that. So the key is video clips saved into packs.
Good. Right, we're getting quite a few questions here. Should all adult intra-abdominal testicles be removed without any attempt at orchidopexy? Adult intra-abdominal testicles. Should they be removed at all?
It depends on the age of the patient, and it depends what size the testicle is. If you've got the capabilities laparoscopically and it's a good, healthy testicle, then there's no reason not to try, as long as you're consenting the patient for an orchidectomy. I think the commonest scenario is you end up with something that's really quite small and fibrosed, and you just have to be mindful of that when you're consenting the patient. So yeah, just because you can doesn't mean you should. To end up with a sort of jelly bean-sized testicle in the scrotum after going through quite major surgery is questionable, the benefit, if the other side is normal.
Just out of interest, I've never attempted it, but have anybody in the audience successfully performed an orchidopexy on an adult male? I'd just be interested to see. Can you provide us with any sort of insight based on your experience with that?
There's a roving microphone, so if you'd like to make a comment, please put your hand up. Yeah.
Sanjeev Agrawal from London. Can I make a comment on this, and then I have a comment and a question for Paul? I do a fair number of orchidopexies because of my increased pediatric practice. So regarding this adult orchidopexy, so long as Paul said, the size is reasonable. Obviously, you don't expect any spermatic function from that testicle, which is in an adult, but there will be some possibility of testosterone function, and especially if it's unilateral. So long there's a consent of regular testicular self-examination and a very close observation, there is clearly a role for bringing the testicle down and fixing it in the scrotum. I have done few of those, and I'm following them up, and they have been without any changes, and they've been reasonably happy with that. That's the first point. The second point I wanted to make was that, Paul, you mentioned that about 80% children testicles are palpable, only 20% are impalpable. So out of the 80%, I perform about 75% scrotal approach. And that is a fantastic approach. You can get testes down through a scrotal approach in a 12-month-old kid very easily. Although it's a slightly difficult operation, but it takes about 15 to 20 minutes per side. And if you're doing a bilateral with a single midline scrotal incision, you can get the two testicles down and fix it in 35 minutes. The results are exactly the same. You save the two inguinal incisions, or one inguinal incision, the opening and the closure, and especially the recovery is fantastic. So I would urge anybody who's doing pediatric orchidopexy to seriously consider doing scrotal approach. And there's enough in literature over now last 10 to 15 years of the results are exactly same as inguinal approach in terms of results success. The question to you, Paul, is that you mentioned about the reduction in incidence of testicular tumor in children or adults who have had previous orchidopexy. And I'm just wondering where that literature support is, because the conventional teaching is that the incidence doesn't reduce, it becomes more easy to palpate and possibly earlier diagnosis of a tumor change in the testicles which have been brought down as opposed to testicle which is in the inguinal region. So could you cite where that literature is?
It's Claire Chilvers' paper. Claire Chilvers, I mean, it is contradictory, but that's the largest case series that has looked at the incidence, and the pubertal milestones seem to be the thing that influence things the most. So it's Claire Chilvers' paper. I don't do any orchidopexies via the scrotal approach. I'm aware that occurs. The reason that I don't is because I don't feel you can skeletonize the canal as well. Certainly at the age of 3 to 6 months, you can get to the deep inguinal ring through the scrotum. But beyond the age of 12 months, which is what a lot of us do, I don't think you can adequately skeletonize right the way down to the deep ring. And if you've got a high testicle and you to really get the cord as bare as possible back that far, then it optimizes the chances. But, you know, this is subjective. If it works for you, it works for you. But I think the transinguinal approach is still well regarded and effective.
So just to say on that, even in a 2-year-old kid, with the retractors going up, you can actually literally go to the retroperitoneum, not even the internal ring. So I would just urge that people to consider and just see that in operation. That's a fantastic operation.
Paul, and also Claire, Paul, you mentioned that clinical examination was the sort of mainstay of pediatric cryptorganism. In an adult with absent testicle, would you undertake any imaging? And Claire, what are your thoughts about imaging in that setting of an undescended test or an empty hemiscrotum in an adult?
So we image quite regularly for that, and we do a combination of ultrasound if it's thought that the testis might be somewhere outside of the pelvis, or and MRI. And one of the things that we use even is that we look for the testicular vessels. So we follow them all the way down from the kidneys. And if you follow the vessels, you generally can find the testis, even if it's retrocecal sometimes, you'll be able to find them if you follow the vessel. So if you do your MRI, we usually do a high-resolution T2-weighted axials, and as long as you put your blocks and you go all the way down so that you can see the vessels, you can usually find them. Even if it's just a little streak, you can usually see that they're going to be there. And also you can see that there are no inguinal structures, so you know the testis has never been down there.
And would you proceed that with an ultrasound, or?
It depends.
Does the
Usually
initial
the
investigation-
clinicians have actually made that choice for us. We would do either, so we do a variety of both. But normally if they feel that they're likely to be somewhere near the inguinal rings or inguinal canal, we'll do ultrasound first, but then we will follow that up with an MRI if we haven't found them, yeah. So I think there are ways on MR that you can find the testis quite well. I think that there have been lots of different techniques of MRI used, but we've plumped for doing this and following the testicular vessels, and we found that to be the most easy way to find them. Unless they're obvious, obviously.
And Paul, would your approach be similar in the adult to the pediatric, or would you do imaging in the adult with the empty hemiscrotum?
Very rarely image a child. In the adult, it does have a place, yeah. If you can show a large testicle on an MRI, it guides the conversation in a 20 to 30-year-old. If it converges to what appears to be nothing, that's also informative. But you just have to be mindful that there are false positives, and you don't want to be committing to laparoscopy plus or minus everything else just to find a lymph node. But that varies on the expertise, obviously.
Okay, next question, top of the pile, is should you remove a testicle which becomes atrophic after an orchidopexy?
No.
All agreed on that? No. Okay. Question?
Question from the audience.
Adult archipexy, would you do a biopsy prior to doing archipexy? Secondly, how you monitor it after archipexy?
Sachs, what would you do with what would
This is an adult testicle.
an adult who you're going to do an orchidopexy? Would you do a biopsy?
Yeah, because if you exclude intratesticular germ cell neoplasia, then you could probably say at 10 years your probability of developing a germ cell tumour is going to be negligible. So that's one important thing. The whole point in bringing it down is either to preserve testicular function, hormonal function. In rare cases, somatogenesis can be induced. I've seen that. But you're going to be following up, you won't be following that patient routinely. The whole idea is to get the testicle down into a position that the patient can palpate and feel that testis. So I wouldn't routinely follow them up thereafter unless there was a specific indication to do so.
Eric, you any thoughts on?
No, I think following up with SUCS, I think you have to biopsy. I think because you say if it's negative in the long term, you're very much reassured about their low risk of developing something in the future. So I think you have to.
And both of you, if you did find ITGCN, what would you recommend the patient do?
Well, you probably in that setting you'd probably remove it, wouldn't you? Really, I think there'd be, you'd have to remove it. I've never actually had that thus far, but I'd probably be saying you need to end up removing it.
Yeah, obviously assuming the other side is normal. I mean, I think we've had a few of these discussions in our MDT, and the oncologists very much advocate, low dose radiotherapy because they insist that the hormonal function of the testis is preserved. I'm not always sure that's true, but that's the message they keep on throwing at us.
Yeah, and it's actually not true.
Yeah.
And if you look at studies, there are analyses done which show that actually radiotherapy is probably just as bad as giving as even gonadoblative therapies as well in terms of hormonal function, and that's been well documented in studies.
And there's obviously the risk to the testis as well with your injecting scrotum. So I would advocate removing it probably.
Yeah, and then also just to highlight, there was an issue you mentioned earlier about somatogenesis, of course, and those patients recovering somatogenesis after, for example, radiotherapy or chemotherapy. What's quite interesting is that you want to try and actually, we may be coming on to this in a second, try and preserve sperm before you do orchidectomy, because there's evidence that sperm aneuploidy rates and DNA fragmentation post-adjuvant therapies is increased. So in other words, it's not just about getting sperm in the ejaculate, it's actually the quality of that, which in theory could result in more congenital malformations and failure of perhaps ART or assisted reproductive technologies. So I think there's another issue surrounding adjuvant therapies in that setting.
Great, we've got another question addressed to Paul. It's maybe slightly unfair, I don't know what your knowledge of paediatric anaesthesia is, but do you still recommend surgery for undescended testicles at 12 months in light of recent anaesthetic papers questioning the cognitive outcomes for paediatric general anaesthesia?
Well, that is out of my comfort zone, but you do get parents asking the anaesthetist that I work with exactly that, and he just said, it's not rock solid evidence at all. It's my understanding is that the risk of an anaesthetic for a child is greater than 1 in a million of any significant complication, And yeah, in the same way about the risks of malignancy we mentioned with the pubertal, it's conflicting. No, I mean, I don't think there's anything more than a sliver of evidence, and it's not compelling. So as far as we're concerned in our department, we just crack on and do it.
Okay, that's great. Any other questions from the floor before we move on? Okay, we've got plenty of questions here. So addressed to Sux, I guess. Should all hypovascular lesions less than 5 millimeters be considered benign? I mean, you did talk about potentially you can biopsy those very small lesions, but would you say that you couldn't accept them as being benign lesions?
Yeah, I understand. I think you have to define non-vascular, if either non-vascular or vascular, because clearly, you know, having hypovascularity would still imply vascularity. So I would argue that if it's less than 5 millimeters and it's non-vascular, I think you can safely monitor that lesion. The protocols, of course, depend upon locally and the availability of scanning and also, of course, patient follow-up. It's interesting, the data I was just showing you there of those 99 units who we actually operated on the follow-up of those patients. And that's why I was trying to get the data to up till now. These are from 2015. Only actually about 50% of those patients came back for follow-up ultrasound scan. So this is one of the problems, of course, in terms of follow-up of these lesions. Hence, definitive biopsy may be better off. You may be better off in those group of patients. But 5 millimeters is a controversial area. I mean, in our data, 5 millimeters we didn't show any evidence. But if you look at the paper by Schlegel, and remember this is an infertility group, so your data is going to be slightly biased, as we know that group of patients have a higher risk of testis cancer anyway, in fact 20 to 50-fold. However, we didn't find that threshold of 5 millimeters, but I think it would be reasonable to biopsy a lesion, even 5 millimeters that was perhaps or greater that was non-vascular, because again, you've got to work out a differential in that group of patients, and there aren't that many other differential diagnoses, are there? Unless it's trauma, hematoma, and perhaps sarcoid, adrenal rest tumor.
And I was going to ask Claire, is there a threshold at which, for the Doppler flow, your confidence in its accuracy sort of hits a point where you know, is it down to sort of 3 millimeters of the Doppler accuracy is debatable, or?
Yes. Well, so Doppler's operator dependent, machine dependent. And so what we would normally do with some of these really tiny lesions, and absolutely agree with you, some of these small lesions are a real problem. We would probably do an interval scan. We'd probably get a second operator to take a look before we actually made a definitive as to whether it was vascular or not. Most of these come to us from the sonographers, and they get a repeat consultant scan to check them. But it can be very, you know, these are the ones that we worry about. And, you know, we sit there and debate whether or not to take them out or whether to watch them. And I don't think that there is an absolute hard and fast rule.
I mean, the other subtle radiological or ultrasonography abnormality is that of microlithiasis, and I'm sure we all see patients who've come along, they've had vague scrotal symptoms, ultrasound's been performed, and the patient's got bilateral microlithiasis, and there's always a question mark at the end of the radiology report about possibility of testicular cancer or risk of testicular cancer. In the absence of other factors such as cryptorchidism, subfertility, are there any risk factors or things we should take in mind with that?
I mean, I think the first thing you mentioned, didn't you, those factors such as small testicular volume, volume of less than 12 milliliters, age. This is the data from SCACA back, in fact, Steve Harland as well. And we're talking about intertesticular germ cell neoplasia, age less than 30. These are some of the factors you might wish to take into account. Cryptorchidism as well. So that picture I showed you earlier was a patient who had a cryptorchid testis, who actually had a Leydig cell tumor, but quite florid microlithiasis in a small testicle. You may be more prone to trying to biopsy that testicle. But if you're talking solely testicular microlithiasis alone, of course, the data remains very controversial. And it's quite uncommon in the absence of those other risk factors to have TML that's that florid, according to the grading system, alone. So I think that's quite very rare. In that group of patients, I think you're obliged to scan the testis, and I think it depends upon the stage or the grade of TML that you're seeing in the absence of all those other factors.
I guess the other dilemma that we often are confronted with is the indications for biopsy of the contralateral testis in someone with testicular cancer. Eric, what are your sort of thoughts on when and who to biopsy, routinely or a subgroup?
Well, I think it's very much picking up on some of the risk factors Such just mentioned there based on the historical data. I have to say, in everyday practice, I'm still sort of hunting for that patient who really falls in that category to do the contralateral biopsy, and I think actually it's a very, very small minority in my experience.
Yeah, I agree, and I think those risk factors, again, I mean, this is historical data from Skackerback, showing that, small testicular volume, age less than 30, and, the degree of TML, if there's TML present or not, all probably are factors you should take into account for biopsying, and that's what I would rely upon. But as you said again, there's not that often you have that patient, of course, that has that.
We're going to have to draw this to a conclusion, but just one final question, very practical. In a DGH setting and someone with an undescended testis that's impalpable, the question is, why not do an ultrasound? Because if it's visible on the ultrasound, you could do an orchidopexy locally. If not, you've got to send that child a long way to the centre. Any hard and fast rules?
No, there aren't, no.
Yeah.
I mean, ultrasound is very, very limited in what it will show, and it depends on your local expertise. There's not really much more in dissecting it.
Great. Well, I just want to thank everyone for coming along. I want to thank everyone for using the question forum thing. That's been really helpful. We've got lots of questions, didn't get through them all. I guess, in summary, there's a lot of take-home messages. I think from Eric's talk, for me, it was make sure you do offer a man, or at least have the discussion about testicular prostheses prior to an orchidectomy so they're not unhappy afterwards. I think from Claire, getting your sonographers to record ultrasounds on difficult lesions on their CD, DVD, so you can review that properly at the X-ray meeting, I think is very helpful. We've discussed the role of ultrasound-guided biopsy in indeterminate testicular lesions, the small lesions. Certainly that's not something we do in our centre, but certainly something we're now going to consider, I think. And for the undescended testes, yes, orchidopexy, we're going to aim for doing them at 12 months. But remember that there is the retractile testis, where they don't need an orchidopexy. And then remember that's a difficult operation in adults, so maybe try and persuade the adults to go down the orchidectomy route rather than list them straight for an orchidopexy. Thanks very much for your attention, and we'll draw that session to a close. Thank you.